Hello, everyone. I'm JD Osborne, Vice President of Surgical Products and Services for Corneal. Thank you for participating in today's course titled When to DSEK versus DMEK. With advances in the DSEK and DMEK procedures like nano-thin tissue for DSEK and the goiter preloaded glass cannula for DMEK and the new Endocerter PL for DSEK, choosing which type of EK surgery and process offering is appropriate for your case can be a challenge. Dr. Giegengack and Dr. Walter join us today to discuss their thoughts on when and why they choose DSEK over DMEK and vice versa. Will they agree? Will they disagree? You'll have to watch to find out. Today you'll hear about the complex EK cases and when DSEK or DMEK is the better choice. You'll learn about the advantages and disadvantages of each procedure. You'll get to know the latest innovations in DSEK and DMEK surgery. And finally, you'll get to ask your questions throughout this live webcast. You can submit a question anytime during the webinar by using the questions box in the upper right-hand corner of your screen. Click on the plus sign. It will open a text box for you to write and send your comments or questions. We'll use the last 10 to 15 minutes or so of the webinar to answer any final questions you may have. We'll do our very best to answer as many of them as possible during our allotted time this evening. If you'd like to experience the Endocerter for DSEK or transition to DMEK, please know that Corneal can help. Please contact us at info@corneal.com and one of our surgical product specialists can provide you with research tissue and tools while coaching you in a one-on-one wet lab or join you in the OR as you perfect the techniques before your first DSEK with the Endocerter or DMEK procedure. Corneal is also currently providing a free trial opportunity of the Endocerter for DSEK to get the experience with the device prior to the preloaded Endocerter, which will be available here pretty soon. Now, let me tell you a little bit about today's instructors. First up, we have Dr. Matt Giegengack, who is currently a board-certified associate professor at Wake Forest University Eye Center and is co-director of the Wake Forest Cornea Fellowship Program. He directs the Wake Forest Eye Center Global Outreach Program, teaching and performing corneal surgery in Honduras, El Salvador, India, Nepal, and Ethiopia. He's a very busy corneal transplant surgeon performing PK, DALK, DMEK, nano-thin DSEK, and SLET. Welcome, Dr. Giegengack.
Thanks for having me, JD.
Dr. Giegengack, you may be familiar with our next colleague this evening is Dr. Keith Walter, who's also a board-certified ophthalmologist specializing in cornea and refractive surgery and is the professor of ophthalmologic surgery at Wake Forest University in Winston-Salem, North Carolina. His desire to improve corneal transplant surgery led him to invent and develop the Endocerter corneal endothelium delivery instrument. Welcome, Dr. Walter.
Thanks, JD. We're happy to be here.
All right, before we get into it and you guys play nice, we're going to have just a few poll questions to get started. And we want to better understand our audience members' experience levels with both DSEK and or DMEK. We've developed a few poll questions to learn a little bit more about our audience and participants. During each poll question, you'll be able to click on the answer that best reflects your experience level. And so you can see here our first poll question: do you perform DSEK or DMEK surgeries? There's a DSEK and DMEK option, or neither. We will give it just a few more seconds here. And Emily, if you can please show us the results of our audience. Looks like a little bit more than half of our participants tonight perform both DSEK and DMEK. We have about a third with DSEK only, and we've got a good bit with neither. So maybe we can talk them into trying these procedures here this evening. For our next question, if you perform DSEK surgeries, how many per year? And you see your choices here below. We'll give it just a few more seconds. Nobody's voted for 21 to 30 yet. And our results, kind of a mixed bag. We don't like 21 to 30 DSEK procedures a year. We'll have to do some more market research and get back to you on that. But a good mixture of volume and experience here for DSEK. And I believe we have one last poll question this evening. If you perform DMEK surgeries, how many per year? Poll questions and answers are coming in. We'll give it just a few more seconds here. Alrighty, and the results, yet again, nobody likes 21 to 30. That was a great age group. 31 and plus, a good bit, but it looks like the vast majority is 1 to 10, so maybe starting out with the DMEK procedure, and a good portion also from 11 to 20 per. So looks like we have a very diverse group of participants here tonight. Thank you so much for your feedback and engagement. It's now time for me to hand it over to Dr. Giegengack and Dr. Walter, who will present some very fascinating information tonight. Dr. Walter, take it away.
Thanks, JD, and it's an honor to be part of the faculty tonight with my partner Matt Giegengack. As you mentioned, we're both from Wake Forest University, and it's kind of fun to have Matt as my partner because we do bounce things off a lot of each other. We don't have too many arguments, but I think we'll see how it goes tonight. I'm trying to get my slides to work, and it doesn't seem like I need to have my slides, I guess, handed over to me. All right, here we go. Yeah, still not working. Maybe we'll have just the next slide for me. All right, there's my financial disclosures. Of course, I'm a medical advisor and get royalties from CorneaGen. I also do some speaking and consulting work with J&J Vision. Omeros has kind of faded a little bit, and Shire and Sun Pharma as well. So next slide. Ed Holland did help me with these slides. So I want to give a shout out to Ed. A lot of this is his data. So let's talk a little bit about endothelial keratoplasty, what that is exactly. And I think if we think about it, DSEK is kind of a lot of different things, or at least it's been a lot of different things over the years since it's come out the last probably 15 years. There's different thicknesses, there's different diameters. I think we all originally started cutting our own tissue. Maybe the thickness was over 120 microns, could even be up to 200 microns. And then we realized maybe not so good, we'll do some thinner cuts. So we did maybe 120 microns or so, and then we kind of got thinner than that, less than 100. And then now, a lot of what we're doing now and what we'll talk about tonight is sort of this nano thin, which is around 60 microns or less. And then if you think about it, DMEK's really just one thickness, right? It's just that endothelial layer with a little bit of decimase, no stromal thickness. So DMEK, when we talk about DMEK, it's pretty much the same for everybody. We might vary the diameter, but we don't vary the thickness like we do with DSEK. And I think that makes a big difference because we want to compare apples to apples. Next slide. So again, eye banks were instructed to cut tissue originally pretty thick, around 180 to 200 microns. The nice thing about thicker tissue is a little easier to handle. You could actually use forceps to insert it. Maybe there was a little cushion from the stroma so that you could squish the forceps a little bit, and you wouldn't really damage the endothelium. So we thought that was probably a good idea originally. The problem was that thicker tissue had kind of a higher rejection rate, around 10%, and we had a very slow recovery of vision with a hyperopic shift. So many of you who started with maybe 9mm grafts or 8.5mm grafts, a really wide, thick tissue, had a real thick edge because of the way it was cut. And so you would get this hyperopic shift because you're putting a myopic lenticule in the eye. And so, people would start out maybe even +2 or 250, and then slowly over a year get down to +1, maybe if you're lucky. So we realized that we needed to change like our DSEK phaco nomograms to account for that hyperopic shift. Next slide. So that's when we started thinking maybe thick isn't as good as thin. So this is one study done, printed by Cornea Society, and the EBAA. And it, at that time, thought the term of thin was less than 100 microns, mean was 100 microns, and the thick was 140 microns, but you see it even got up to 180 microns on that range, whereas the thin tissue had a low end of 60 microns. And just in this small study, you could see the ability to achieve better than 20/25 vision was about twice as good in the thin group. It was only 30-something patients in each group, but 82% were 20/25 or better in the thin category versus only 44% in the thicker category. So we were already starting to see that improvement in visual recovery going to thinner DSEK tissue. Next slide. So that evolved a little bit more. We got a little thinner than that. I know Busan started publishing some ultra thin, so maybe less than 100 micron. Then, of course, about this same time, Mellis came out with the idea of DMEK, like let's go all the way to no stroma and get it as thin as possible, and maybe we can even improve our visual recovery and our results even a little bit more. So next slide. Of course, DMEK has the advantage, and I will concede to my partner and those of you who do DMEK that it does have a faster visual recovery, probably does have reduced higher order aberrations and a lower rejection rate. Next slide. However, the disadvantages is there's probably a little more tissue loss in preparation, although that's improved with some of the things that CorneaGen has developed, and knowing maybe the age of the donor has a bearing on that. But the other disadvantage is a little bit longer surgical time, at least initially. I think there's a longer learning curve for surgeons who are starting that. And there's a little bit of unpredictability with the unfolding of the tissue. There's a lot of tapping and banging going on in the cornea that I see with my colleagues that do this. I know that if there is a open posterior capsule, there can be an issue with vitreous coming forward during that tapping and banging. And it may lead to a little bit of higher complication rate, at least early on, with a higher detachment rate and a higher rebubbling rate. And a lot of the studies have shown a 10 to 30% rebubble rate with DMEK. And maybe the endothelial cells get a little bit beaten up and we lose a little bit more cells, either from the prep or from the actual insertion of tissue. So there are some disadvantages with DMEK, and maybe why it hasn't fully been embraced, even though it's been out probably 8 to 10 years. Next slide. Although the outcomes are good, if you look at Price's study of 136 eyes at 1 year, 98% saw 20/30 or better, which is impressive. 80% were 20/25 or better, and there were a lot of eyes that were 20/20 or better. Again, the endothelial cell loss at 1 year was 36%, which you might think that's remarkable, but I will submit to you and to my other half that maybe endothelial cells don't really matter that much as far as our loss rate. Maybe we can lose quite a bit of cells. Maybe they're difficult to count pre and post-op, and maybe it doesn't have any bearing on our survival, but it is higher in DMEK than it is in DSEK. There are some primary graft failures in this study of about 8%, so that might be a little bit higher than DSEK when we look at the data, but it's pretty comparable. Next slide. If we look at, again, a sort of a review of comparing head-to-head DMEK versus DSEK, this was published in 2017 in Cornea. DMEK is superior to DSEK for visual acuity, like I mentioned. The central corneal thickness is less. Patient satisfaction surveys seem to be higher. The post-operative endothelial cell density didn't really show that much difference in this study, but there was, loss in both. However, in this study, it did show that DSEK is superior in DMEK with respect to rebubbling. So maybe if you have a patient that doesn't tolerate rebubbling that well, or doesn't like to go back to the OR, or maybe incapable, maybe we side towards DSEK in some of those instances. Next slide. So is it a fair comparison? Though, again, one of the things about these studies you need to realize, again, is that DSEK is so variable with both thickness, diameter, the prep, how it's inserted, whether it's forceps, a needle, over a boost and glide, the endoserter. I think really with DSEK, and we tend to be, as surgeons and maybe as doctors, we tend to like to lump things together. Like we lump LASIK together, right? When LASIK first came out, there was a lot of commercial. Was LASIK good? Was it not? Was it better than PRK? And again, PRK was pretty much one thing, but LASIK could have been done with a microkeratome. It could have been done with a femtosecond laser with a flap. It could have been a LADAR LASIK laser. It could have been an Alcon Allegretto wave. It could have been a Vizx. And LASIK was all kind of lumped into one category. But I think the technique and the way and the thickness of the flap in that case made a difference on LASIK outcomes. And we can tell that LASIK can be better. Same with even now with femtosecond cataract surgery. I think there are some lasers that are better than others, and we tend to talk about femtosecond cataract surgery as one thing, but it's maybe 3 or 4 different things. Same with electric vehicles. We can talk about electric vehicles. Are they good? Are they bad? What are they doing? But there's lots of different kinds of electric vehicles. There's Tesla on one end. There's Rivian now. We've got the Chevy Bolt still. So I think it's different to different things. So I think keep that in mind when you read a study about DSEK. It can be very variable. And one of the things we never study actually is diameter. And I think the thought always has been, let's put as many cells as we can in the eye to help improve our outcome and maybe long-term graft viability and survivability. But I would submit to you that maybe a thicker, larger graft is going to have that hyperopic shift and maybe have a little slower recovery. If you think about a thick DSEK graft with a wide diameter is going to have that really thick edge where endothelial cells have to grow over. So you can have this bare stroma on the edges that DMEK doesn't have that can delay visual recovery. So one of the advantages of nano-thin DSEK is you reduce the thickness of the tissue overall, but we've also gone to reducing the diameter of the DSEK tissue. And now I do 7 1/4 diameter max, and I find that I get much more DMEK-like results and faster visual recovery, less hyperopic shift. And I will submit to you a lot less rejection as well. Next slide. Yeah, and again, I think I just sort of mentioned some of those things. We don't really talk about some of the older DSEK techniques. When we talk about DSEK, there is, again, a new kid on the block with the thinner tissue and better delivery systems. If you look at all these DSEK studies, they rarely report diameter, thickness. Even Price in their group does a really good job with their data and their studies. They don't report diameter of their grafts. A lot of us with DMEK have gone to smaller diameter grafts with DMEK to help the unfolding process. And we don't think twice about doing a 7 millimeter or 7.5 millimeter DMEK. But when it comes to DSEK, there's a lot of us that feel like we got to do an 8, 8.5, or 9 millimeter graft, which I don't think it really helps us that much. That larger volume of tissue probably increases the antigenic load, and you get that higher hyperopic shift, which I just mentioned. So next slide. So in one study, this is a good study out of Cornea, Ed Holland's group in 2018. He actually looked at head-to-head. Well, let's look at the best DSEK has to offer. Nano-thin DSEK in about 30 eyes versus DMEK in about 30 eyes. All of them had no other morbidities except for Fuchs dystrophy. Straight up, just Fuchs dystrophy. Let's compare apples to apples. A little bit better controlled study. 6-month follow-up. And let's look at visual acuity and postoperative complications. Next slide shows the results. And what's cool about this study is there was no statistical difference in visual acuity at 3, 6, and 12 months. DMEK slightly outbid DSEK or nano-thin DSEK at 1 month. So you got a little faster visual recovery with nano-thin DSEK at 1 month. But all the other time frames, it was not statistically significant. And again, that's what I'm finding too. If I use nano-thin DSEK, it's very DMEK-like in our results. Next slide. All right, I'm going to hand it over to Dr. Giegengack, and he's going to tell you a little bit about his thoughts on pros and cons of DMEK versus DSEK.
Thanks, Keith. Let's see. Sure. Okay. So just my my disclosures. I'm a medical director for Cornea Gen 2, and this is a Cornea Gen talk, so I have that bias. And then I'm on the advisory board for RM Biotech, and the other ones that you see there. There's a little bit of redundancy in our slides, so I'll try to skip over stuff that we both have talked about. But one of the neat things about being asked to do this webinar is it made me kind of look at my numbers and see what I was doing. I mean, I have it in my head that I'm a DMEK surgeon, and I just asked Cornea Gen to supply me the tissues that I've done this year, and I think of myself as a DMEK surgeon, but here I have done 35 DSEKs this year so far too. So while I seem to be preferring DMEKs, I'm still doing a lot of DSEKs, and I'll try to get into why that is. And a lot of it will echo a lot of the stuff that Keith was saying. Just a shout out to Keith and I, we've had 13 cornea fellows, and I think JD said in my bio that I was the co-director of the cornea fellowship here. Keith and I co-directed. I'm proud of the way we teach DSEK and DMEK to our fellows. That's a few of our fellows there standing with me. And then a quick shout out to the Cornea Gen team. This is a photo of a lot of the ones that work here in Winston-Salem in the Cornea Gen office that prepare our tissue and allow us to be excellent, humbly excellent DSEK and DMEK surgeons. Couldn't do it without these folks preparing our tissue for us. And then those terms that I had there are ones that Keith already defined well, but nano-thin DSEK, which is what all of those DSEKs that I've done now this year are, is a DSEK that's less than 60 microns, and that's a change from the way it used to be. And I totally agree with Keith that lumping all of DSEK into one entity when comparing it to DMEK isn't fair, because DSEK has evolved just the way, even while DMEK has come on. But here, so if I have a patient that has isolated corneal endothelial dysfunction, this is kind of my order of operations, I guess, that for a patient that could have any of those surgeries, a DMEK is preferable to a nano-thin DSEK, which is preferable to an ultra-thin DSEK, which is preferable to a old-fashioned DSEK, which of course is preferable to a PK. It wasn't so long ago that we had to argue that DSEK was better than PK, but of course we all agree with that now. And then it was for a while we had to argue that getting thinner on DSEK made any difference. And I'll try to make an argument for DMEK versus nano-thin DSEK, and when I would do one and when I would do the other. But just looking at DSEK as just like Keith said, lumping all of DSEK together and comparing it to DMEK. If you do that, DMEK is definitively a better visual acuity. One of my favorite things about DMEK over DSEK of all varieties is that they get better quicker. It's not unusual to have a patient seeing very well at a week and a half, whereas my DSEK patients can take several months to get driving vision, and they even continue to get better over the course of a year or two. Another advantage that Keith alluded to of DMEK over DSEK is that even with the nano-thin DSEK, you're putting in some sort of a minus lenticule, and there is some variability in your refractive choices, and DMEK is much more predictable what lens to choose if you're doing it in combination with a phaco. I have a lot of patients that were sent to me back in the day of just DSEK that had multifocal lenses, and the Fuchs discovered later, and getting that bit of extra visual acuity that you get with DMEK makes it so that you don't have to exchange the multifocal lens. And then less donor tissue means less rejection. And then an advantage that Keith didn't mention, which is surprising, in the beginning of DMEK, especially when you're learning DMEK, it might take you longer to do that surgery. But now a DMEK surgery is a faster surgery for me in the OR because depending on how you do DSEK, a lot of people do a 10-minute wait period when you put the air bubble in. It's like the longest 10 minutes of your life when you're sitting there doing nothing. And in a DMEK, you don't have that step. But then advantages of DSEK on this same thing, my DMEK patients, I put SF6 in their eye and they lie flat on their back with increasing break time over the course of several days. And with the DSEK, I just have them lie on their back for a day and a half or so. A big advantage of DSEK over DMEK that we don't mention a lot is that DMEK tissue is much easier to manipulate if the donor is older. And I know the eye banks have been stressed because with the rise of DMEK, there's kind of a run on donor tissue, 55 and older, whereas it used to be the other way around, that we were always looking for younger donor tissue. And with a DSEK, you can use that younger tissue, and so that's a neat thing. And then the big advantage of DSEK is it's easier in a complex eye, which I'll talk about. I don't do a peripheral iridotomy on DSEK, and that's a small advantage. And then nanothin DSEK versus a standard DSEK. The only advantage of a standard DSEK is that it's easier to handle than a nanothin DSEK. And nanothin, just like Keith was saying, they get better vision, they get better quicker. There's probably less rejection because it's less of an antigen load, and then a more reliable refractive outcome because it's less of that hyperopic shift of a graft that's thicker on the edges and thinner in the middle. And I would submit that that if you use the endoserter to inject your tissue, that the easier to handle advantage of a standard DSEK kind of goes away because the endoserter makes nanothin tissue very easy to insert. I would also say that nanothin tissue put in with a method like the needle push method or the forceps fold method is hard, and I wouldn't recommend it because I think you do damage to the tissue. You need some sort of an injector for nanothin tissue, I think. And then I guess the big question is nanothin tissue versus DMEK tissue, which is better? And that's kind of what this talk is about, because Keith and I both do nanothin tissue. And in my hands, having done a lot of both, I think the DMEK sees a little bit better and gets better quicker and maybe has less rejection. But if you see in parentheses, I put here a little and less dramatic. The gap between DMEK and DSEK with the now very available nanothin tissue has shrunk, and that means that if I have an eye that is just isolated endothelial dysfunction and it's just normal Fuchs dystrophy, then I'm going to do a DMEK. But if I have an eye that has something funny going on and I'm not sure if the DMEK tissue is going to be easy to unfold or various different reasons, which I'll talk about, my threshold for saying, no, I'm going to do a nanothin DSEK on those patients is very low, because the difference in outcome has gotten so much smaller. So it's sort of a risk benefit thing, like everything else we do, really. But going on. So DSEK is here to stay, and one of the things that preparing for this talk sort of did for me was I decided that I would jot down all of the instances when I would prefer a DSEK over a DMEK, and there's a lot. And I realized I pretty much was writing down everything other than Fuchs dystrophy, isolated Fuchs dystrophy. And if you look at this list here, eyes with abnormal anterior chambers, well, ACIOLs is a common reason why I might treat somebody with corneal edema. And if they have a deep enough chamber in an ACIOL, I'll do a DSEK on them. If it's a shallow chamber in an ACIOL or a malpositioned ACIOL, I'll do a lens exchange in a DSEK. If they have had a tube or a trab, you can do a DMEK on those eyes, and I've done it before, but it's tricky to get the gas bubble to stay in long enough. It's tricky to unfold the tissue around a tube. And it isn't tricky for me to put a nano-thin DSEK tissue in there. And so now if I have a patient that's had a glaucoma surgery, I'll go right to the nano-thin DSEK. Aphakia, the unfolding tricks that you have to do for a DMEK would be foolhardy to do in aphakia. And if I have an aphakic patient with corneal edema, I can use the endoserter and insert the tissue over a sheet slide and be very successful. Failed PK, one of the main reasons I might do other than Fuchs, that I might do a EK now. I've done DMEKs on those. I've seen the DMEKs sometimes will get have a tendency to curl up on the interface between the PK graft and the recipient bed, and it's hard sometimes to get the DMEK to center just so that it's all within the failed PK. And a DSEK tissue, for those of you that do it will know, it's pretty easy once you get it in there to take your Versinski and slide it to wherever you want, and you can center it on that PK just nicely. So that's my go-to for failed PK. Post-vitrectomy, sometimes I'll pick DSEK over DMEK because sometimes those eyes are hard to get the chamber shallow enough to unfold the DMEK, though. If you get an older DMEK tissue, lots of times I'll still do DMEK on those. Unstable lens, Keith kind of alluded to that, the tapping on the cornea that we do. If you have a lens that isn't stable, you can make it more unstable, and vitreous in the anterior chamber is failure for either DSEK or DMEK, and it's very easy to gently put in a DSEK tissue without dislodging a lens that might not be totally stable. Long axial length, also hard to shallow the chamber. Patients with positioning issues, when I do a DMEK, and this isn't the same with everybody, but when I do a DMEK, I'll put in SF6 gas, 20%, and that gas will stay in their eye for 4 or 5 days, and I'll have them lie on their back with increasing breaks for all or parts of those days. And I only do a day and a half or so with DSEK, and you have patients that can't do that kind of positioning. The other thing is that my detachment rate on a DSEK is probably about 1 in 50 that I have to do anything like put an air bubble back in there, and my detachment rate on a DMEK it's a different kind of detachment because they don't come all the way off when a DMEK attaches, and sometimes they just need a little bit more air put back in there, but it's about 1 in 8 when I might have to squirt just a little bit more air back in there. And a patient that has trouble lying flat might not enjoy a second in the office procedure either. Patients with a question mark visual potential, remember that the vision benefit of DMEK is only slight over the nano-thin DSEK, and if you have a patient with a macular scar, what are you gaining them by doing a procedure that has a slightly higher complication rate? The only thing you might be gaining them is a quicker recovery, and that could be worth it, but it's worth considering if they don't have 20/20 potential, why push for a surgery that has 20/20 vision at a higher rate than one that has 20/25 vision at a good rate. Global outreach is a thing that I do a lot of. DSEK tissue, if you're able to get it and bring it somewhere, needs less long of follow-up. Usually if I do a DSEK on someone in a place where I might not be for long, I can know that they're stable after a couple of days and feel good about putting them on a drop regimen and leaving them in someone else's hands. Whereas DMEK, you can get a detachment a week and a half down the road, and you kind of want to have someone that's seen that before around to take care of it. So DSEK can lend itself to global outreach a little bit better, except to say if it's somewhere that you're going where you have to prepare your own tissue, I can prepare my own DMEK tissue with very little tools, where the things that you need to prepare DSEK tissue is more complicated. So that would be an exception to that. Let's see. Yeah. So just if you are going to do nano-thin DSEK and you are going to use the endoserter, and we're going to talk more about this. I just had this slide in because I thought I would give a little some little tips for that, because when I made the switch from normal thickness or ultra thin DSEK to nano-thin DSEK, the tissue does behave a little bit different. It kind of almost behaves partway between a DMEK and a DSEK. And if you use the endoserter to insert it, it's important that you don't run the same amount of fluid through the eye when you insert it, or it can kind of get bunched up. And I think I was showing here that if I'm doing it with a hanging bottle, I lower the bottle to about as low as it'll go, and I keep the bed high. And if you're doing it with the with your phaco device or your Centurion, I put the IOP at 30, which is different than what I did for a thicker tissue. And that I think Keith's going to tell us a little bit about what he's doing with the endoserter now.
Yep. Cool. Thanks, Matt. That was great. Awesome. And we can talk about the endoserter preloaded, which is coming to an OR near you soon, hopefully. They're just ramping up production. Matt and I have had some early user experience with it, but I'm very excited about it because it definitely is a new and improved endoserter, but it's also a new and improved container for your cornea. So what you see there on the very tip of this is a little tiny bit of Optisol, and the tissue is in this little container right here. So now we're not using a big volume. It's preloaded. It's to your size. I think 7.5 is the max diameter, and like I've talked about before, if you're using nano-thin tissue, probably 7.5 is all you need. I tend to like 7 or 7.25 at the most. It fits in the endoserter perfectly. It unfolds perfectly, and it gives you good results, both faster visual recovery, less hyperopic shift. So what's cool about this is you'll get this tissue delivered to you in this container with the endoserter, and it's preloaded. All you have to do is take this little lure lock off the end of it, and then take this lure lock at the end of this off and hook it to an irrigation. And like Matt said, very small amount of irrigation. You want to let the irrigation flow, your BSS flow through till it drips off the end here. You'll have like a little container just in case it might want to come out. It tends not to unless you really blast it with a lot of fluid. But what you're doing is just sort of rinsing the Optisol out of the chamber and off of the endothelium, and letting that kind of drip into a collection chamber. Once that's done, then this blue part right here, which you might recognize as new, you can untwist it and it pops off. And now you have the basic endoserter for all intents and purposes that you guys have used in the past that can go into the eye. But now it's preloaded. All you have to do is put it in the eye and then unsheath it like you normally do. So I think it's definitely going to be I think it's going to be a 100% replacement, because your eye bank tissue will come this way. It'll be a pass-through charge for your tissue, and this device will be included in that pass-through charge, the way I understand it. And so it'll probably be more available to a lot of you who maybe the cost was prohibitive initially with the endoserter, because it was an additional fee outside of your global fee you got for the tissue or for the case. Again, preloaded makes it easy, makes it more DMEK, even more DMEK-like, and I think you'll enjoy this device when it gets in your hands.
Just piling on to what Keith said. I mean, the data really does show that the thinner tissue is better, and the thinner tissue with a lot of the injection methods is harder to handle. And I I like the endosurgery as a way to make nanothin tissue easy to handle. And then like you said, the barrier has been the cost, but with the preloaded, it all gets sort of lumped together. And I mean, I think the brilliant thing about your invention, Keith, you're not allowed to talk about the brilliant thing about your own invention, but is that it's is the coaxial irrigation. So you put it in there, and through one opening, you have a maintained anterior chamber, and it's just a very stable way to get the tissue into the eye, and it protects it while it goes through the wound. So it's pretty awesome.
Yeah, one of the unexpected niceties I found with it is that I don't have to cut my tissue in the OR anymore, which wasn't a big deal, but sometimes the tissue would not get cut exactly right, or maybe it was a little off center and you have a thicker edge, or sometimes the tree fine, maybe I guess it would splay open a little bit and it would get caught in that little notch in the round blade. So that little anxiety has gone away with this device, which I didn't really even think about, but it's kind of nice not having to worry about that.
And that's actually a cost savings, because those tree fines aren't free, the donor punch.
Right, and they're not covered either.
Yeah.
I think next is questions and answers, right, JD? Are we up to our Q&A?
Yeah, absolutely. And so one quick update there, as you mentioned, Dr. Walter, we are anticipating having full availability of the Endocerter PL coming out of Academy, which will be just not too far away in October. Also, the Endocerter PL is FDA registered, and it will hold up to 100 microns in thickness, or as we've explained tonight, maybe a lot thinner, as well as up to 8.0 millimeters in diameter or less. And looks like we've already got some questions rolling in about that diameter, Dr. Walter, Dr. Giegengack, so we'll be coming right back to that shortly. Great job. We can't thank you enough for sharing your incredible wealth of knowledge and experiences with us. I personally enjoyed hearing a little bit more about the journey and the innovations from DSEK that maybe some of our younger colleagues just feel like, nanothin or 60 microns was always out there. But I can remember starting a few years back where 100 or 120 microns was considered thin, as well as the appropriate patients for DMEK. So a lot of great information there. Just before we get to those questions that you provided during the broadcast, if you haven't already, there's still time to submit your questions by clicking on the tab that says questions in the box in the upper right-hand part of your screen. When you click on the plus sign, this will open a text box for you to write and send your questions. So we already have a few here, and we will get started. I believe you guys touched on this, maybe not so much the first part of the question, but here goes. Ideal diameter size for DMEK and also DSEK. So Dr. Giegengack, do you want to talk to us a little bit about your ideal, or maybe your general diameter for DMEK, and then also for DSEK, but then Dr. Walter would love to hear you follow up with, once again, kind of hammering home your findings with a smaller diameter.
Sure. So one thing that I teach our fellows is a difference between DSEK and DMEK, is that DMEK doesn't attach well to an area of the cornea that hasn't been stripped. And so I'll strip a larger area of Decimase than the graft that I'm going to put in. And then if you look at some things that Mellis has presented on, where he'll take a single donor tissue and break it into 4 pieces and put it into 4 different eyes, he's pretty much shown that you don't need to put a whole lot of DMEK tissue in to get a good outcome. Having said that, I use 7.5 millimeters for the size of the donor graft when I do DMEK, and that's worked really nicely. I do think it would be fine to go smaller, but I've had such good success with that I haven't done it. Back in the day of preparing our own tissues, there were a couple of times that I tore one in half and I still put it in and it did well. So I do know that they do okay smaller, but 7.5 is what I picked and it's working, so I haven't adjusted it, but you could go smaller if you wanted to. And then with DSEK, since I went to the preloaded, I've been doing 7.5 and I've seen no decrease in my outcome from the 8 that I used to pick. So that supports Keith's theory.
Yeah, again, we really haven't studied this. These papers are published, but nobody publishes on diameter. And I think, back in the day of PK, we thought, a larger graft would be better for just giving more endothelial cells to the patient because it's the square of increased number of cells as the diameter gets a little bit bigger. So what I've found is that's true, but even in our PK days, we did an 8 millimeter graft. We were probably putting stitches in at around 7, or so. So we're probably losing a lot of that peripheral tissue, and they did fine. Initially with DSEK, I was doing 8.5 on a lot of grafts and even larger, thinking, well, if I had a larger cornea, I'll just put as much as I can. Definitely harder to unfold and get in the eye, especially in a shallow chamber. And then also, again, that hyperopic shift's real. So if just to review, when we're cutting DSEK tissue, we're taking a planar amount off of the surface of the eye. So if we're taking, let's say, 250 or 300 microns off the surface of the cornea in a planar fashion, we know that the cornea is thicker on the edges and thinner in the middle. So, and it gets bigger as the diameter increases. So the larger diameter, you're gonna have a lot thicker edge. And I always wondered why the 8.5 millimeter grafts in DSEK, especially if it wasn't nanothin, or even if it was, just took a little longer to heal. And their vision would come around, but like Matt said, sometimes, their best cutie was a year or two out, and then they would look fine, but they always looked a little thicker on the edge until very, very late in the post-op period. And I think what has to happen is the endothelial cells have to grow across that stromal edge, even go vertical to close that edge before they can actually shrink that tissue and make the cornea normal. So the thicker the edge, the longer that takes, and the hyperopic shift is worse. So both those things are working against you. So again, you're learning from my DMEK colleagues that they're doing 7.5 and doing fine. I'm thinking, well, why am I doing 8.5 DSEK? Doesn't make any sense. Maybe I should do less. So
just one more point, but I think it might matter a little bit to the diagnosis that you're treating. If it's Fuchs, it's sort of a central corneal disease, and if it's pseudophakic bullous keratopathy, sometimes those people have edema limbus to limbus, and maybe there's an advantage to a bigger graft in those.
Yep. Yeah, that would be you're right. That'd be the asterisk on this conversation. But that brings a good point, Matt. Like with Fuchs, even with DSO, we can strip 4 millimeters or 5 millimeters, a real small amount, and allow the cells to grow in. So, maybe, as we mentioned earlier, the endothelial cell count isn't the whole thing. The volume of endothelial cells isn't really reliably studied. And these patients have done really well. I think it's been probably 3 years now that I've gone to about 7.5 as my max on DSEK, and we've gotten great results. So they look a little funny. You got to get used to it. You look at it, you'll see a smaller button in the eye, especially on a larger cornea, but the grafts are clear, the edges are thin, they're seeing great, they're very happy patients. So I'm all for 7.5, probably max is where I'll ever go, even on a larger cornea. Maybe you're right, Matt, on a more widespread endothelial disease, I might go a little bit bigger, but for your bread and butter Fuchs patients, yeah, I would stick with the smaller.
Here's a great follow-up question to that. With the smaller diameter grafts, do you see a higher incident of MCE on the peripheral host tissue? And how do you address that if it bothers your patient?
I don't. I tend to strip smaller with DSEK. I think you can get away with stripping smaller. So true. If you do strip like an 8 or 8.5 and do a 7.5, you will get that little band of bare stroma where you could get some MCE. But I think as long as you strip smaller and stick to that, then you're doing fine. I don't know if Matt has a comment on DMEK.
I agree that if I strip an area that's larger and then I do a DSEK, which I don't do if I'm paying attention, I will get a peripheral edema that takes longer to heal. Just like he said, I strip a smaller area with DSEK, and with DMEK, it's pretty awesome how quickly that donut of overstripped area gets better. The cells they just march right off because that's what they're supposed to do. Yeah.
Here's a question. What about PDEK? PDEK. Do you have experience with the PDEK in complex anterior segment cases instead of DSEK?
I don't have any experience with that, but I've never been a big believer in it. I didn't quite understand how it was better than anything we do now.
I mean, I like the idea of it, and I don't have experience with it. I think it's the same idea as nanothin. I mean, it's not quite DMEK, but it's a little bit thicker, so you can handle it well. And that's what we get with nanothin, and places like CorneaGen are so able to provide us reliably nanothin tissue right now that I don't see the need to pick that one up. But it's a good idea, I think.
Dr. Giegengack, could you explain more about why it's advantageous to obtain DMEK grafts from older donor patients?
Sure. Especially when you start. I mean, I have a slide that I like to show sometimes where JD, I think you had me teaching a course at Academy or something, and it was a wet lab where we were handing out the tissues, and you had in a petri dish, you had 10 prepared DMEK tissues, and they were all kind of floating around in there, and they were very different. I mean, there were some that were super tightly scrolled, and there were some that were just unrolling themselves, getting ready to put themselves in the right place. And the older tissue scrolls less tightly and is much easier to unfold in the eye. It looked like 13% of the folks on the poll or whatever were low in their numbers of DMEKs a year, or 0 DMEKs. There were those out there, and if you're thinking of starting to do it, talk to your eye bank, talk to CorneaGen, whoever's supplying you, and tell them you want that first tissue to be 65 or older, and it'll make your job easier. I can handle a tightly scrolled one now, but in the beginning it made you sweat.
And Dr. Walter, this question is for you. With DSEK, I hear more and more surgeons are creating a PI to use more air in DSEK procedures as they would with DMEK. Dr. Walter, what is your thought here on the DSEK airfill, and have you made any changes to this in the OR over the past few years?
I've definitely thought about it because, Matt does the inferior PI on his DMEKs, and I hear from the fellow how well that works. And it can be a little bit difficult to do at times, and you might get a little blood or a little mess, but it works. And I've thought about that, especially on a small pupil that doesn't dilate well, or like an IFIS type iris where you don't get a real good dilation. For me, I've always been like, if I can get a good dilation, and I'm a big proponent, and I know this is different than what like Mark Terry and some other folks teach, but I keep the pupil dilated the whole time. I never constrict the pupil. And I think if you can get a well-dilated pupil, you won't get a pupillary block with a well-dilated pupil in the right size bubble. And that obviates the need for a PI and DSEK, because the bubble's only there for about 24 hours, really, maybe a little bit more. So if I'm doing DSEK phaco, I dilate the eye like I normally do with any phaco, and I keep it dilated the whole time, and I don't constrict it inserting the tissue. I think it's a myth and not been studied that you have to have a constricted pupil to insert your tissue. I think it's better to have it fully dilated, and the tissue tends to float up, especially with the endocertor. When you put it in, it tends not to slam down against the IOL or the iris. It tends to kind of float up, and at least the central cells do. Now, sometimes you will get a shallow chamber after you take it at the endocertor, but all you have to do is just put your air bubble in and you'll get a deep chamber, and the tissue tends to go near the right place or in the right place, and then you can adjust it from there. So I've not been a big proponent of a PI, but I've thought about it, and I've thought maybe in these IFIS patients, it's a good idea.
It kind of, one of my I guess my least favorite complication in the whole world from DSEK or DMEK is pupillary block. I mean, if you have a DSEK detach or you have a DMEK detach, you have it fail or whatever, I can fix that. If you have someone that has terrible pupillary block overnight, you can blind somebody that way, and so I like the idea of never getting pupillary block, and you can never get, if you do it right, you can never get pupillary block without doing a PI in DSEK, but you have to know a little bit more what you're doing. That DSEK has a difference from DMEK in that you put that air bubble in there and you make the pressure very high for 10 minutes or whatever kind of pause you do, and then you have a responsibility to take a lot of that air out. And people get their pupillary block when they don't take as much of the air out as they think they should. And so the way I don't get pupillary block is I take all of the air out, and then put the right amount back in after my 10-minute break. And then I know I haven't left a big reservoir of air behind the iris. And if you do that, you don't need a PI, and a PI isn't totally benign. I mean, I've had issues with a PI and a DMEK surgery where it bleeds and it can cause trouble. And because it's gas, I need to put it in there. But if you don't need it, don't do it. And there's techniques in DSEK that you can do to not get pupillary block, but you gotta be sort of diligent on them to be careful. You know, you got, like everything else we do, you got to be careful. Yeah.
With our last few minutes here, of course, we've got a few questions here on your preloaded endosurgery experience. And so the first question, really simple. It sounds like you two have been able to experience the endosurgery preloaded. Have you noticed any difference in post-ops at day 1 or week 1 or further versus manual insertion of DMEK or non-preloaded to date?
No, I mean, I think I get the same good results with the preloaded DSEK that I get with the self-loaded endosurter. It's been a long time, years, since I've done a DSEK in the United States without using the endosurter. So comparing the preloaded to the endosurter to other injection methods, I can't really do. When I had to do it, it's been other places, and that's not a fair comparison. But
Dr. Walter?
I like it.
Yeah, like Matt said, I've been using the endosurter self-loaded for a long time. Can't tell any difference between that and the preloaded. The OR is the main difference, where it's a lot easier, less time. So very streamlined, very nice device in that respect. Post-op looks the same. Back when I used forceps, I used to do the trifold, a lot higher incidence of detachment rate, the tissue being a little bit more kind of rough handled. You could see more edema, maybe a slower visual recovery, but of course we're using thicker tissue back then, so that was part of it too.
One of the neat things about the preloaded one is that you have to decide what size you want before, and I used to kind of hem and haw over what size I was going to put in there, and I haven't been because it's been decided for me before, and I haven't seen it make a difference. so
That's good to know, and maybe you should listen to your partner, Dr. Walter, over there a little bit more.
I try to, but it probably shows you that the diameter doesn't matter all that much, and maybe a little smaller is easier to handle and just as good. So that has been a neat thing with the preloaded. It saves me time because I don't have to load it, and it saves me time because I don't have to think about how big it's going to be.
Right. Dr. Walter, this may be a little bit better equipped for you, or you can also call a friend. I'm here for you. The question is, with preloaded DSEK in the endosurter, the stroma is subject to fluid for an extended period of time. How does that affect clearing time?
So it's in the Optisol like it normally is. So that part's really no different if you're talking about that fluid. If you're talking about the irrigation fluid, it's very minimal. We're talking maybe 2 cc's probably clear out the Optisol. You're not rushing a bottle of BSS through it. So you're only doing maybe 2 cc rinse, which I think is good. I think there's some belief, and I'm one of those that if you have too much Optisol on your tissue, it tends not to stick as well. I remember I always rinsed my tissue when it was self-loaded. I always made sure it was in a container of BSS, just maybe 5 or 10 milliliters to kind of keep it rinsed. And then once it goes through in the eye, again, we're only using probably 10 or maybe 20 cc's to insert the tissue. I think it's even less than that. It's definitely way less than what you'd use during a phaco. So the amount of fluid irrigation you're getting there is way less than what the endothelial experienced during a standard cataract surgery for sure.
Yeah, and a little bit of more insider information here from the technician perspective, as in with surgeon loading. One of the unique things about the endosurter is that the stroma really is not does not come in contact with the Optisol or the media storage for the preloaded, because the stroma sits down on that amber orange platform, and the excess fluid is removed, which really adheres the stroma to the platform. So kind of the way I read that question, or a technical answer would be, to date, we have not seen that stroma or any issues, it sounds like, with either of you two for any post-op swelling, things of that nature. Would that be a fair assessment thus far?
Yeah, I'm a little bit surprised at that question, because it's definitely not something I've thought of, because I haven't seen it at all clinically.
Great. And our last question here, this will be a fun one. Is there more endothelial cell loss with preloaded tissue compared to tissue cut and loaded into the OR? And we'll make this a DSEK question. I think that's what the direction is. I
know that both versions of the endoserter had to go through studies on endothelial cell loss, and whether we cut it in the OR or the technician cut it, or it was preloaded or we loaded it. And I believe you can probably tell me, because I don't remember the data exactly, but it's very comparable. It's not really any different. You do lose some.
I'm sorry, Dr. Walter. Again, I'll assist here. The interesting thing to note is this is FDA registered, unlike all the DMEK preloaded options that is considered a class 1 device. And so all the data that was presented to the FDA was rather impressive, that there was no statistical significance in a microkeratome DSEK cut put into a corneal viewing chamber like every surgeon in America is getting today, versus that DSEK that was then punched and loaded into an endoserter. No statistical significance in swelling or endothelial cell loss. So we were actually kind of surprised by that as well. I do want to sneak this question in. I said one last question, but someone did get this last one in. Dr. Gig.
You know what? You're just like a patient. They always say that. One more question.
One more. Dr. Gig, you kind of touched on this, but we have a surgeon here that says, I want to try nano-thin DSEK. Any tips about loading the thinner tissue onto the endoserter without damaging it? Now, this surgeon says, should I just wait for preloaded? I don't think we should have to make him wait for preloaded with nano-thin in the endoserter. Dr. Giegengack, what are your thoughts and pearls there?
Yeah, so we've been doing nano-thin for a long time before we had the preloaded one, and there are a couple of tricks, JD, that you actually told me in the OR when you brought it, and I appreciated that. If you're using the endoserter, you got to kind of drag the tissue onto the endoserter platform, and putting a tiny little bit of fluid on that platform to drag it over helps keep the very thin tissue from bunching up. And then and that's one trick. And then when you're injecting it, you just want a little bit of a decreased flow than what you would normally have. So a lower bottle height or a lower pressure on your phaco device if you're doing it with that. And I would say actually inject it a little bit slower, because when it comes out, it can come out a little bit bunched up relative to what you're looking for. And if you might have to, pronate or supinate your hand a little bit just to get it going the way that you want it to, it's just don't just inject it really quick, but watch it when it's coming out to see that it's going the way you want it to. It's not hard, but it like lots of things that we do, you do it right if you pay attention to the way you're doing it. Got to pay attention.
Yeah,
Dr. Walter, any other last pearls on that?
Yeah, I was just going to say that now's the opportunity to get a free regular endoserter before the PL is widely available, and if you haven't used it, this would be a good opportunity, I think, just to get familiar with it, because it's really not that hard. The original endoserter is pretty easy to load. Of course, the PL makes it even better because you don't have to do that loading part, but it would be good to just experience how it deploys the tissue, how you unsheath it. That part's similar. So I would take advantage of CorneaGen's offer and use a couple free ones before you get your hands on the PL. Just get your feet wet, get your experience going.
It's
Matt said.
It's an addictive tool if you have it, and you're presently doing things like the needle push, and then you get to try a couple of endoserters. It's like drinking a nicer bottle of wine and then trying to go back to the other one. It's easier. It's nice. It's user-friendly.
Smoother.
Well, it's amazing how these hours always go by. Dr. Giegengack, Dr. Walter, many thanks to both of you. You both did a terrific job. I was wanting to see a little bit more arguments, but you guys clearly work well together and have to see each other tomorrow. So thank you for playing nice. Once again, if you would like to experience the endosoder for DSEK, as Dr. Walter just mentioned, or even transition to DMEK, please know that CorneaGen can help. Please contact us at info@corneagen.com, and one of our experienced and trained surgical product specialists can provide you with the research tissue, tools, OR support, including a wet lab as you practice the techniques before your first use of the endosoder or the DMEK procedure. Again, Dr. Walter, you stole my thunder. CorneaGen is also providing a free trial endosoder of the endosoder for DSEK to get experience with the device prior to preloaded. Again, available here very soon. Following tonight's session, we will be emailing you a link to access
How many free devices can they get?
And a survey soliciting your feedback. We ask that you take just a few minutes to complete the survey, as your comments will help guide us in presenting the best possible educational webinars in the future. Once again, many thanks to today's phenomenal instructors, Dr. Giegengack and Dr. Walter. I also want to say thank to all of you